He's opening his eyes. Hey, Dad. He opened his eyes when we first got here, real wide, and moved his head like that and looked at us. Hey, Dad. Dad. Bertha's here.
Hi, babe.
Hey, Dad.
Hi, babe.
So he's not, they just said that he's not having seizures. What the movements that he has is something called myoclonus,
Yeah, that's what he said.
but it's not seizures. And they said that's not going to harm him. According to that bald doctor over there, Dr. Linkyu, he said that the jerking movements, the only time they would be concerned with his jerking movements is if like his tube goes in and out, or he bumps his head on something. Hey, Dad.
Hi, babe.
You see Bertha? He's trying to cough. But he looked over your way. They said he's not dead too. They said he's still alive. The machines are obviously helping him to continue to breathing and stuff. So he really opened his eyes big and wide and looked right over at me when I came in. I mean, do you want to hope for a miracle, Bertha, or do you want them to take the machine off, or what?
I don't know. It's painful to see like it. It's affected me a lot. I went to the doctor and I don't know. It's affected me a lot. It seems like that on it.
Well, I know it's affecting all of us, but the good thing about it is that he's not having seizures.
Yeah.
Jonathan is thinking that these are seizures. They're not seizures. If he was having seizures, then would be more worried about it. But these are just jerking movements that they call myoclonus.
That's what the doctor said. The local doctor.
And in my opinion, he's looking better. I mean, he opened his eyes wide and he looked right at me like that. You can ask Gary. So he's not dead. I asked the lady right there, that nurse, and she'll come and tell us right now if he's brain dead, and she said he's not brain dead. She said if they were to say that he's brain dead, then that would mean that he's legally dead. But he's not. Obviously the machines are helping him, but he's still alive. Huh, Dad? Huh, Dad? Huh, Dad? Dad. Hi, Dad. You're still alive, huh? Huh, Dad? You know who I am, right? Your son, Jacob. Huh? Huh, Dad? In the name of Jesus, we plead the blood upon you, the blood of Christ upon you, and that resurrection power. We dispel all darkness in the name of Jesus. By his stripes you are healed. Pascual Robles, by his stripes you are healed. You're going to come out of this, Dad. There's a lady that had an injury like this. The doctor on the internet, and the doctor said she had an anoxic brain injury like him, and that there was nothing left of the brain, but she recovered. I mean, if we believe in God, we can hope for a miracle, man. Why can't we hope for a miracle? We all deserve a miracle, and especially this servant of God here, you know. God could heal him, and I don't feel good about turning the machine off if he's still alive. I mean, God made these machines. He allowed man to create these machines to help us, you know, and a lot of people come out of these comas. Dad, see, look at that. That's more movement than I've ever seen. His eyes opening more than the other days I've been here. Hey, Dad, you know Bertha's here, right? Dad, open your eyes if you know that Bertha's here. Open your eyes big. Can you open your eyes big, Dad? Abre los ojos. Dad, abre tus ojos. Ciérralos. Cierra tus ojos. For some reason, he's more awake than the other times I've seen him. They said that they're gonna put the tube in his throat. That the doctors are gonna come and do that procedure pretty soon. I don't know if it's today, but in the next few days. Because this right here, the tube in his throat, could cause some complications. So the tube in his throat would be better, they said. And this lady will tell you right here. So the tube in his throat, the tracheostomy, would be better than this tube here in his throat.
For long-term use, the medical recommendations are that you put the tube in. I mean the trach in. In the medical world, you hardly ever see endotracheal tubes in for more than 14 days.
And the doctor said that we're at that time frame.
We are.
To move to the next
Correct.
Stage, which is the trach in his throat.
Trachs are more permanent. They can be permanent, and it's for use for life support, for continued life support.
But like you stated earlier, he's not brain dead.
He is not brain dead. He does have severe injury to his brain.
Right.
But he is not brain dead.
If he was brain dead, then that would mean he's legally dead.
Correct.
Because his brain couldn't send messages to the rest of his body.
Correct. There would be nothing to tell anything to function. Even what we call them brain stem reflexes, the most basic function of any human, would not be intact. They wouldn't work if you were brain dead. And so he couldn't even tell his lungs to breathe. I mean, his brain couldn't do that. So brain dead.
At this point in time, there are signals from the brain telling his heart to keep beating.
Yeah, technically yes. The heart and lungs work so let me kind of explain what happens. Your heart and lungs work very close together. You obviously can't have one without another. If one is compromised, the other is also compromised. So his heart is under a lot of stress. If we were to remove the breathing tube and not replace it with something, just let him breathe on his own. We talked about that he would die within a matter of time. We don't know what that time is.
Right.
And a lot of that comes down to, number one, he's not breathing well. Number two, his heart is under so much stress because he's not breathing well. So they work together. So that
So is the ventilator helping with some of that stress
yes. Yes.
on his heart?
Yes. Well, I mean, with some of it, yes. We can't take out, the complete stress because having a foreign body doing the breathing for you is stressful. But we are relieving some of that.
Okay.
Absolutely, by doing the breathing and providing his body with oxygen.
Okay.
That's the purpose. That's the whole purpose of the machine is to
Right.
do what the lungs can't do.
Okay. Mechanical lungs.
Yep. That's what they used to be called.
Really?
When you can look, if you look on the internet and search like how the inventions of ventilators have come.
Uh-huh.
It used to actually be a tube, a machine that they laid people in because they realized if they put enough pressure, it would squeeze the lungs, and then they released the pressure, the lungs would kind of open. Now, if you can imagine, that wasn't very effective.
Yeah.
Somebody who couldn't breathe, putting them in a tube,
Yeah.
like kind of like a huge tube.
Yeah.
Yeah, mechanical lungs. There's lots of different inventions. That's
Wow.
kind of where it all started.
That's interesting.
So people have known for a very long time that if we could figure out a way to get the lungs, to do that work,
Yeah.
the oxygen would come in and out. And so what we're doing is actually the exact opposite in a scientific way that our bodies work,
Uh-huh.
but it's the best way that we can possibly do that. So we still get oxygen, we still inflate the lungs and deflate the lungs.
Okay. Hey, Dad.
So you see how the eyebrow twitches, like when you
Yeah.
when you touch it, it's the muscle. It's not technically a muscle spasm, but that's what I think of it as. It's like you stimulate the muscle, it kind of spasms.
Like his nerves or something?
Muscles.
Muscles. Because this right here, what is that? That's a vein, right?
Yeah.
And that's not technically a nerve.
No, we can't see nerves. They're deep down inside.
Deep down inside?
For good reasons, to be protected. If we
Yeah.
were near the surface, we could. I mean, in our fingers, I suppose, since our fingers are only this thick, the nerves, of course, aren't that far in. But in the rest of our body, they're kind of tucked away as far as they can be because that protects them the most.
Uh-huh. Okay, well. But it's good to hear that they're moving forward on this trach thing.
So ultimately, that won't change anything about what's going on. I mean, his condition, but it will make it will make him able to kind of keep going on that road
Uh-huh.
or this current road. You know what I mean? So don't expect that anything changes.
Oh, I'm always expecting for things to change because I'm a religious man.
No, I mean because of the trach.
Oh yeah.
You can expect him to change. That's no problem.
Right.
But because of the trach, it doesn't do anything, a particular thing for the condition.
Right. But it's better than this
For long term.
tube. Yeah. Okay. Yeah, because he's been here since the 5th. What's the day? The
17, 18.
18th.
Let me freshen his mouth. Yep.
So he's just doing a lot of like coughing, huh?
Yeah.
No. You're just gonna say one word or what?
One word for 1 second.
Oh yeah.
Okay, so I just want to talk to you about plans for after he gets the trach and peg today or tomorrow. We obviously don't know when. So whenever someone in the hospital here gets a trach and a peg put in, there's only one facility that they can go to after their hospital stay, because there's only certain facilities that can take care of the trach and the peg as well as all of the other medical things going on with them. And those are the long-term acute care facilities. Remember, we were trying to get him to those before he came down here.
Yeah.
Remember that?
Yeah.
But he
Are you the girl that I talked to on the phone?
well, you talk to me and Lindsay a lot.
What's your name again?
Shay.
Oh, okay.
Yeah.
Okay.
Yeah. I know there's
You
been
given
a lot
that
of
many
people.
before?
Yeah. Multiple times.
Okay.
It's okay. So we were trying to get into that, but remember Humana wouldn't authorize it because they didn't think he was appropriate for it.
Right.
Right? Okay, so now that he has this trach and the peg, definitely that is the only type of facility he can go to. So there's no way that Humana can tell us no on that.
So Humana will.
They're gonna have to, yeah, because
Okay.
really, I honestly can tell you, any patient that we have down here that gets trach and peg, they go to an LTAC. That is what happens.
Okay.
Because they are the only type of facility that can manage his care.
Okay.
So.
Where's that at?
We gave you that list, but there's like 6 of them. I can give you the list
Okay.
again. I will send referrals out just to all of them like we've been doing in
Okay.
the Denver area, and we'll see who gets back to us. I know that Porter would be a really good choice, and let me tell you why, and it's right here in Denver. It's within Porter Hospital, so if anything, he had any needs, he's within a hospital that way.
Okay.
Really convenient. The other thing is National Jewish. All the doctors that have been following him down here follow over there.
Oh, okay.
Continuity of care would be really good.
That's important.
So it is important. So I would say that we maybe pursue them first, because what Humana will do is they'll only allow one of them to start authorizing the insurance. If there's like 5 or 6 of these facilities trying to get Humana to say yes, they're gonna back out. So we don't want to scare them away,
Right.
basically. So with your permission, and I'll talk to Laura about this and run it through with everyone before I do anything, but with your permission, can I send referrals to these LTACs, and which one do you want me
Well,
to?
I like the one that you're
Porter first.
thinking about.
Okay.
Yeah.
So why don't we try Porter first?
Okay.
And then if that for some reason doesn't work out, we'll go to the next one and I'll walk you through that process at that
Okay.
time. Does that sound like a good plan?
Yeah.
Okay. All right.
Okay.
We'll go ahead and do it. I like to get the process started early. I know he doesn't even have them yet, have the trach and peg yet, but that way when he's ready to go, we can just go. There's no hold up in the
Good
care.
plan.
Okay. All right.
Okay, thank you.
Yep.
Because, yeah, in a lot of ways, technically they'll keep him in the ICU as the ventilator, but if we put in a more permanent solution, he can go to these places, he doesn't need to stick around
Okay.
in the hospital.
Plus, you guys might need some bed space for other patients.
We always need bed space, but that's not, I mean, seriously, we always do. That's not really an issue. I mean, it
Okay.
is an issue, but that's not your issue. But it's, it's kind of, you're working, kind of are in maintenance mode. And so if you have a trach and peg and you
What's the
move
peg?
on.
What's the peg?
That's the feeding tube.
Oh, okay. So that's different than colostomy peg.
Yes. So it'll be on the other side. So right now he has that one that goes in his mouth all the way down into his stomach. It's sitting next to that ET tube. But this one is a little tube that kind of fits right here in his
And there's
stomach.
like a little hole. There'll be a little
There's a hole.
there.
Yep, just a little
And
hole.
then you just attach a bag to it or something?
No,
or?
no.
Oh.
So it has a tube that comes out of it, and then like the feeding that he's getting
Yeah.
plugs into that tube.
Oh.
So the feeding goes directly into
Oh,
his
okay.
stomach.
Okay.
Or his medication, we crush them up, we push them through these syringes or the tubes, and it goes right through that tube right into his stomach, so
Okay.
it can be absorbed into his body, just like if we were eating. It just kind of skips this whole part.
Oh, interesting. Okay.
Okay.
Well, thank you.
So that's the next plan, and that will put him, at a position where we can start moving on to these longer term facilities.
Okay.
And Shay will work on that and let you know whenever she finds out.
Thank you for being helpful with the information. I don't think I have any other questions.
Okay, you let me know if you do. I don't know.
I'll be hanging around the hospital for a large part of the day. so-
Okay. Then if we see, let me know when you're leaving for good.
Okay.
Because if
What time will you be here till?
5.
Oh, okay.
And then because if we hadn't seen trauma by then, at least I know that you've gone, not just left me the this unit for a while. You know what I mean? It's like maybe if you went to go get lunch or you went to the waiting room. If,
Yeah.
if that team comes by and say, well, I think he's still in the hospital, let's have him come back up here.
Okay.
Okay?
Okay.
Hey, so I wanted to give you their information. So that's the name, that's their address, and their main phone number. Morgan is the one that I'm gonna be in contact with,
Okay.
and she said you can call her if you have any questions. You can go over and just tour without an appointment.
Okay.
You just go, I mean, it's really close here. So if you want to, call or go over there, you can do that at any time. And if you wanna talk to her directly, that's her cell phone number.
Okay, thank you.
Yep.
Yeah, so you can definitely encourage you too, if you can call her and go tour it. So
Yeah.
I don't know if you live near here,
But, well, I really don't, but.
I mean, but while you're
It's on our
here-
way to the house.
oh, okay. Or I was gonna say, while you're even here today, you could just like
Take a quick
stop by
ride
there.
over. It's not too far from here.
No, like less than 10 minutes.
Okay.
Let me give you my card again,
And
too.
just-
Oh, okay.
No, you're fine.
Okay.
And just look at it and kind of see what's actually the facility is about, what it means to be there and what goes on.
Good idea. Well, thank you.
Yes.